So I've now got a pile of questions in front of me, which is fantastic. There seems to be a couple here addressing the problems that health professionals may actually have in recommending this diet. And I'm suspecting that this is with reference to professionally. So I think I might ask Gary to address that question. The question, is it safe for health professionals to advise patients to do low carb, high fat? And there's several other questions relating to the Health Professional Regulation Agency as well.
Yes. But yes, it's safe for all of you because, APRA put out, I call it APRA because I don't give them the respect of calling it APRA, but they put out 14 press releases in 2016, and I managed to get 2 of them. So I'm the only person who seems to be able to get more than 1 in a year and 1 in a lifetime. And I got 2 within 2 weeks, which became part of a Senate inquiry. The first one prompted another Senate inquiry, and the second one came out saying that all medical professionals can give dietary advice. It came a week after I challenged it, and it became, reported to APRA. I reported APRA for contempt of Senate, and I got them successfully charged with that. Anyway, long and short of it is they have got a document there that says that all health professionals can actually give specific individualised dietary advice. But that's probably prompted from what I did back to them. I get reported annually by dietitians and to the medical board. I've helped, and the last time I got reported, that was tossed out within a few weeks. I've successfully helped a few doctors here in Australia and one particularly in Canada who were all the same story, and they've all been let off. APRA and the medical boards do not want to go here again, not when this is becoming mainstream. My issue started, like Rod, I started talking about this several years ago. So in 2012, if you're advising your patients to not have sugar, that's what got me into trouble, because I then gave a handout. I started challenging hospital food. I got one of the things is I said, one of the talks that I gave to the hospital food industry, my second slide was, hospital food is crap and it's killing my patients. Which it is, but it's not killing them on that admission, and so therefore APRA came to me saying, look, we've actually done an audit of your hospital patients and none of them actually died from hospital. I'm not kidding. And so therefore I said, it's a figure of speech. But that came back to me. That was in the final thing, that we've actually done an audit. We've got to the hospital and none of your patients died. It is still a recommendation in the dietary guidelines for hospitals that if you have diabetes, you're supposed to get the standard diet, which includes at least 2, but preferably 3 desserts per day. And when you go, that's not true, I go, here is the document, and it's still existing as of 6 weeks ago when I last checked. So health professionals, you can feel safe in giving this advice that is now mainstream. I quote, look, here it is, the CSIRO are on board of it. Guidelines are shifting and changing. It's becoming very mainstream. And if you do get reported, give me a holler, because I've got all the information to help you out.
Okay, so by accident or by fate, we've got 2 orthopaedic surgeons sitting up here next to each other. And as they say about orthopaedic surgeons, they're strong as an ox and twice as smart. So
careful, we'll come and crush you.
Good to have you here. I'd like to transfer the same question over to Dr. Sher, who's also an orthopaedic surgeon. Just ask, have you had any pushback at all you're obviously a passionate advocate for low carb and healthy eating for your patients. What have you found the feedback has been?
Well, I guess the first thing to say is that I'm further back in the herd than what Gary was, and he stuck his neck out and they tried to chop it off, and I learned from that lesson. So really from when I first started with this 3 years ago, all of this was still very much in the media, and I didn't know what was going to happen. And so I really set things up so that even though I was a very strong advocate of it, even within the clinic, I would talk to people about it, but say, look, you've got to go and see Paul if you actually want official dietary advice. So I did that in response to what happened to Gary. But since that time, since I've watched everything happen, I've now become much more open about it and will actually talk to patients directly about it. I've started lecturing on the science of it as well as the benefits. And today's talk wasn't so much about the science, but if you go to our website, you can see at the last fitness convention, I did a whole lot of lectures on the science. Last year's November lectures, there's science of ketones as well as fat loss. So I'm a very much believer in the strong science behind it. I talk to my patients about it all the time. And in fact, it takes longer to have a consultation to talk a patient out of a knee replacement and to go on a diet and convince them that it's actually safe for them to do so than it does just to book them and consent them for an operation. And so, you know,
Now, one thing that Doron didn't mention there, which is a bit of an aside, the cancellation rate that he mentioned before of people cancelling their surgery after losing weight is probably somewhere between 30 and 50% of what he's saying. So, now,
I've talked many patients out of surgery for a couple of years, and then when they actually do come back, they're in far better nick, which you talk to. And they are enthusiastic and they're engaged in their outcomes far more than when you just operate on them literally cold. The situation of financial side, some of you may know Sean Baker in the US, if you follow him on Twitter. He's an orthopaedic surgeon there who in fact got into hot water because he wasn't doing enough operating. He was a high throughput surgeon. He started talking low carb, in fact carnivore in his practice, and he all of a sudden his practice declined so much that his hospital administration said, you're not doing enough throughput. That's effectively the short story. And then, it's taken him and he's now just got his registration back again. So it is just, it changes changed my practice straight away, which you will have agreed to. And there are a couple of rheumatologists here in Sydney who are now recommending the anti-inflammatory diet as their first pathway in the management of arthritic pains, problems, or traditional osteoarthritis and the inflammatory arthritis. They're not calling it low carb healthy fat, but it doesn't matter. It's getting the message out.
now if we could just move that same question over to Peter Brukner here, who's a very, very well-known sports and exercise medicine physician. And can I add, one of the very few medical specialties that actually has any element of nutrition education within the qualification itself. So I guess to a degree that provides him with a degree of defence of recommending it to his patients. But I understand you've come in for some criticism previously as well.
A little bit, yeah. I'm a bit jealous of Gary actually, because no one reported me to APRA. I'm sort of I've tried to get reported to APRA, but I haven't succeeded. I'm not sure why. But no, in all jokes aside, I mean, I think there is quite a groundswell of doctors and even dietitians who are supportive of this, but they're particularly since Gary's experience, they're terrified to sort of stick their head up and talk about it. We always thought there was only a very small group of us who were keen on this low carb concept. And then last year, a Facebook group started up of doctors interested in low carb and paleo living. And within a couple of months, there was 800 doctors in it. And I thought, well, where are these 800 doctors? But having met a number of them at conferences and so on, they tend to be young doctors, hospital residents, junior doctors who are practicing this themselves and advising some of their patients, but they're too scared to talk about it because their big bosses would come down on them pretty hard. So Big bosses, yeah, the big bosses. As someone said, we've sort of got to wait for this generation of senior doctors and dietitians to die before we... and they probably will if they keep eating. Anyway, we won't...
So it's true, Max Planck said it best: science advances one funeral at a time. So, Maryanne, so you've obviously in a different profession, but you've come under a lot of criticism, and there's a question here about, is there any view to the situation redeeming itself? Does it look like, is there any movements for you to be vindicated following the, I guess, the almost discrimination, the pressure that you've had applied to you following that Catalyst program?
I think, it's hard to say because the media environment is changing so rapidly now, with everybody going to digital media and less television is being made. I know that they brought back Catalyst, but it's a new team and it's a different feel about it, and a lot of people have commented on that. I think that what has happened from my experience and some other journalists that I've spoken to, they're just going out and starting their own independent investigative journalism, which is why I've been publishing with Michael West, who's a former Fairfax journalist, who is independent and doesn't take industry money. So I think that there will be more and more journalists coming out, starting their own blogs and websites. And it's also true for doctors. I've interviewed many doctors who tried to get studies published in the medical literature, and it just doesn't get past the peer review process because often the peers are your competitors. So the medical environment as well as the journalistic environment is incredibly competitive, and there's a lot of...
Well, how did you manage to get an article as a non-doctor published in a very reputable medical journal on statins?
Journalists, investigative journalists have been publishing in the British Medical Journal and other kinds of journals in the past where they do reviews. I suspect that having a science background and having done a PhD in rheumatology and being scientifically literate has perhaps helped. But in that situation also, it did go through the peer review process. So there had to be some people.
And it certainly does give credence to your views. So, Peter?
Well, some of us were actually on the editorial board of that journal, but we won't mention that. Maryanne, one question for you. I mean, most of you would have seen the Four Corners show on sugar on Monday night. If you haven't, I certainly recommend you should look at it you can see it on iView. I mean, did that surprise you that the ABC would come up with something, given your experience, that the ABC, I would have thought, would have been very gun-shy about tackling this whole area, and yet Four Corners took it on. Was that a surprise to you?
It didn't surprise me so much in today's climate because sugar and sugar tax is not that controversial. When I started doing programs in 2012, 2013, it was a lot more controversial. So, much like Gary, if you're a little bit ahead of the curve and not many people are talking about it, you kind of tend to be the person that gets punished for it, and then all of those that come after you can talk about these issues without the fear of retribution and punishment. So it didn't surprise me because sugar's not that controversial anymore. But certainly my experience with the cholesterol programs, very few people in Australia were talking on a public, on a national platform about the role of cholesterol and heart disease and the overprescription of statin medications. And the real disservice to other journalists is that we're just not able to question these medications. There have been very few, in fact, I don't think I've ever seen any media publications since what happened to me be published in any Sydney Morning Herald or The Australian and other newspapers or TV networks for that matter, where they question the overprescription of statins because you just get accused of mass murder.
Okay.
So are they safe?
Well, I mean, this was the purpose of doing the paper, is to say, you know, if we're going to be honest and have a debate about the safety and the harms of a medication, why not hand over all the side effect data so we can actually have a proper debate? So they appear to be safe when you look at the clinical trials, but for the reasons I've outlined today, that drug companies sponsor the trials, they minimise the harms, they exaggerate the benefits. Do we really know what the harms and the benefits are?
It's often been quoted to me, and Maryanne, as part of all listeners, that the pioneers take the arrows and the settlers take the land. And there's a few war wounds, but I've got a nickname called Teflon, so I don't know what that's about, trying to deflect it over time, or nothing sticks to it. But the real message here is that if you're waiting for bureaucracies, big food, big pharma, people with vested interest to challenge their own situation, it's not going to happen. And the real message is that it's social media and it's people talking to each other which is in fact changing this whole situation. It has nothing to do with waiting from a top-down approach. And it is fabulous that there's a little bit of retribution, not retribution, but reply now that Maryanne's work's been vindicated. The early people talking about sugar, it's the same thing that happened with tobacco. The tide is turning, it's turning right now, and it's got nothing to do with us. We might have been there at the beginning or early. It's been debated for 500 years. You are the ones that are making the difference, and you're the ones who are standing up here, turning up here today, and you'll go home and you'll tweet or you'll bake something at a function which people go, oh, that looks strange. And then you start talking low carb. And at the same time they'll go, oh, you look fabulous. I don't know if you know, but I'm 85. my older brother down the side there.
So I might
my
just...
mother, right? This is our son, okay? Because he lives in Sydney, things don't look that good.
So I'll just extend that concept to Peter. So just in terms of political influence and change, I know that you've been in contact with senior politicians in the past. I know you've had some high-profile association with the Australian cricket team where there's been some high-profile supporters from there and the like. So do you see any recent movements in the political field, something more than just a grassroots campaign?
Well, I wouldn't say there's been massive movement. If you just take the sugar tax as an example, I mean, I'll talk a little bit about that in my talk, but the present government has made it very clear that they're not interested in that. As we know, without getting too philosophical, I mean, politicians no longer lead; they follow, and they follow the public demand. And if they think there's votes in something, then they'll go with it. And so until the political parties think that there is votes in a sugar tax or in taking various measures to reduce the obesity situation, then nothing's going to happen. So that's why the grassroots movement, of all of you people, is just so important. I mean, we've all got to get out there and spread the word, and eventually even the politicians will have to set up and take notice. I don't think, I mean, we've sort of talked about, lobbying in Canberra and all that sort of stuff, but our opponents, have vastly more resources than us. Food lobby, and they all have numerous lobbyists in Canberra, and they can outspend us in any sort of political campaign. So it's got to be a grassroots effort, and as I said, that's where everyone in this room is so important, because we've all got to go out there. If every one of you can go out and convince 10 other people, and then they can convince 10 other people, and all of a sudden we've got a massive movement, and no political party can ignore that. And that's the stage we've got to get to. We're getting there, but it's going to take a little while, I think.
Now,
the problem is we're not massive anymore.
just to...
We are a minority group because 2/3 of the population are overweight or obese. So I'm in a minority group now, and so I can...
We have no rights.
Yeah.
Now, just to move the conversation away from political subterfuge, there's a question here for Doron. Could this diet help my knee pain even if it's not caused by osteoarthritis?
So you saw from the lecture that the causes of arthritis are multifactorial and the causes of inflammation are multifactorial. So the short answer is it depends on how extreme you take the diet. So for example, if you're not worried about weight loss, there's still plenty of improvements you can get by cutting out seed oils, vegetables, cutting out all of your omega-3s. And one of the tests that we didn't really talk about today, but omega-6s, one of the tests we didn't talk about today is the omega-3 to 6 ratio, which Paul actually does. And there's very clear evidence that as your omega-3s rise and as your omega-6s drop, you get less inflammation, less asthma, less rheumatoid arthritis. Your risk of living longer, or the likelihood of living longer, is higher. So yes, if you cut out the omega-6s, you increase your omega-3s, you don't have to lose weight to gain benefit. However, the studies do show that people with knee pain, even of normal weight, if they can lose 5% of their body weight, and for some people, maybe they've got too much muscle. And I know that sounds strange, but the extra muscle will put extra load through their knees. So if they lose 1 to 2 kilos of muscle, their knee pain will get less. So it's not always about pushing weights and lifting and making you bigger and stronger, depending on the specific case. All right, so I may say to somebody, look, you actually need to do a little bit more aerobic and a little bit less resistance training to get to that goal. And it's a very, very individual thing, patient by patient. I don't think there's any cookbook approach to any of these things.
One of the things I'm working with rheumatologists here in Sydney is that we are seeing people improve their pain before they lose weight. That's a critical thing. Within weeks, their pain is significantly better. And to try and study that on pain scores and whatever is nearly impossible. But it's all anecdotal. But there's another whole topic about how we may need to think about publishing findings and looking at it as a systems analysis rather than a double-blind controlled studies. But that's why the engineers are totally across this whole topic of low carb and particularly of diabetes. The engineers don't do double-blind controlled studies. They look at raw data and they just compare stuff. And that's an interesting thing we may need to rethink about how research is done in medicine.
Now,
can I just tell you one quick story about a prominent Australian cricketer who had knee pain, and quite debilitating knee pain to the point where he'd virtually had to stop playing. And when I first met him, he was taking a very powerful drug that he was injecting every fortnight to control his knee arthritis. And it was an inflammatory arthritis. And that drug cost $15,000 a year. And he said that after about 10 days after his injection, he would start to get knee pain and he would know that it was time for another injection. So he was injecting about every 2 weeks. He still couldn't train fully. He still had some discomfort, but he was back playing as a result of this pretty fancy drug. And he came to me because he wanted to lose a little bit of weight, and he went on a strict low carb diet. We were actually on tour in India at the time, which is quite challenging to go low carb in India. But those naans are very nice. But anyway, he went really strict low carb, and he came to me 3 weeks later and he said, "Doc, I forgot to have my injection last week." And I said, "What do you mean?" He said, "Well, I didn't have any pain, so I sort of forgot to have my injection. What should I do? Should I have my injection now?" And I said, "Well, no. Why don't you just wait and see what happens?" Anyway, 12 months later, no injections, no knee pain, increased his training, lost a little bit of weight, got his spot back in the team, and had become one of the top 10 batsmen in the world. And no injections, saved himself and the public purse $15,000 a year. So, it wasn't through his weight loss, I don't think. It was through the inflammation that had been reduced. So he was really on an anti-inflammatory diet. And I sometimes wonder whether we shouldn't, instead of calling it LCHF, if we called it anti-inflammatory, we mightn't get so much sort of, opposition from people.
That's what the rheumatologists are calling it. We're going to put you on an anti-inflammatory diet.
And that's a powerful story, and certainly I would second that. I see that in a lot of my patients in the sports medicine clinic. They have undiagnosed joint pains that just magically disappear. Now, just one more quick question, and this will be for the whole panel. We might start with Maryanne, given your knowledge of cholesterol. Somebody asked, what effect does saturated fat have on cholesterol levels, and is this a problem?
Actually, they did they did laboratory studies and showed that if you do increase your saturated fat content in the diet, a lot of people do actually get raised LDL levels in their labs. But the type of LDL is the favourable type. It's the large, fluffy kind of LDL, as opposed to the more atherogenic, small, dense LDL, which is a more favourable LDL profile, and why most low-carb doctors aren't too concerned about that small increase in LDL.
I think the rest of the panel concur.
Yeah, I agree, and invariably their triglycerides levels come down, their HDL, the so-called good cholesterol, goes up, and as Maryanne says, the LDL is variable. Sometimes it'll go up, but it's the reason is as she suggested, and sometimes it'll go down. But I certainly believe, as was previously mentioned, that the triglycerides and the HDL are the important ones, and the single most important measurement you can do in all that sort of lipid thing is the one measurement they don't actually provide in the laboratory sheet, and that's the triglyceride HDL ratio that I think was mentioned previously.
And I think most of you in this audience would know that the LDL most of the time is a calculated number. It's not actually measured. You actually have to do an NMR to work out exactly what your LDL subfractions are, and that's not a standard test in general medicine. So I would say to you, if you're actually worried about your LDL, get your subfractions done, and then find someone that knows how to interpret that for you before getting worried about it.
I mentioned three things here. One is get your lipid subfraction analysis done, because that's actually a true marker of exactly what's going on. The second one is Dave Feltham. Any of you have followed him? He has destroyed the lipid cholesterol in his own studies. I watched his talk from last year's Low Carb Down Under one, brilliant. He is able to move his cholesterol level up and down depending on the Dow Jones index, based on the amount of saturated fat that he ate 3 days before. Just brilliant. It just completely destroys the whole thing. And the third and final one is when your doctor says, I'm worried about your cholesterol, or the doctor says to me, I'm worried if they have saturated fat, their cholesterol's going up. I ask them one question, which gets me into trouble all the time. I say to them, what is cholesterol? And unfortunately, 99% of the health professionals that I ask that question to give me a blank look. And so we have this complete and utter fear-mongering amongst all of society about cholesterol, when it just happens to be the most important thing, keeping ourselves in place as a precursor to all of our sex hormones and our maintenance hormones. It is a joke, and it's one of the biggest cons of the last 100 years.